All right, I've been told I have to stand in the middle for our Zoom folks. Hi, everybody. And hello to those in the room. Thank you for being here in person. It makes such a difference to have you here, creating the community that we all care so much about. So I'm excited to welcome you to our October Leaders in Public Health series. It is my absolute honor to welcome Dr. José Bauermeister, who is both a dear friend, collaborator, and longtime inspiration to me. For those who don't know him, Dr. Bauermeister is the founding faculty director of the Eidos LGBTQ Health Initiative at the University of Pennsylvania, as well as Albert M. Greenfield University Professor of Human Relations, which I think has to be the coolest title ever for a university professorship. Jose received his bachelor's degree from the University of Puerto Rico and his graduate degrees in public health from the University of Michigan. Hey, no, we're blue too, bud. So prior to joining Penn, Jose was faculty at University of Michigan School of Public Health, where he was founding director of the Center for Sexuality and Health Disparities. Over the past 20 years, Jose has conducted extensive research on the unique health challenges faced by sexual and gender minority communities. His work, and this is part of the reason that we have him here today, focuses on not just describing problems, but more importantly on synergizing systems-level interventions, community engagement, digital strategies, and clinical innovations to optimize the health and well-being of LGBTQ+ communities and those who care about them. Currently, Jose is lead investigator on multiple clinical trials, including a digital life skills program for sexual minority adolescent men, a suicide prevention program for LGBTQ+ youth, and a social support platform focused on addressing stigma for Black and Latinx sexual and gender minority adolescents and young adults. Jose, welcome to the stage. We are so excited to have you here today.
Thanks. Hi, everybody. Oh, it is on. Okay, good.
Yeah, they do magic.
Thank you for having me. It's really an honor to be here.
Well, I'm so thrilled. I mean, one of my favorite things about doing this is getting to see people who I just think are awesome, you amongst them.
You can critique that later.
And I will say, as we were sitting here talking before, this is, of course, a no judgment zone, but also so we can be a little more spicy with each other.
Yeah,
and that's
for sure,
okay too.
for sure.
So to get us started, if you don't mind sharing, you're looking out at a group of students, faculty members, staff, both here in person and online. And one of the things that I love to start our conversations with is talking about the career journey. I'd love to hear about your journey from public health to being a PhD student and researcher to moving into the digital innovation space. You mind sharing a little with folks in the room how you got here?
Sure. Let's see. I grew up in Puerto Rico. English is my second language. You might hear my cadence change a little bit today because I'm thinking in Spanish. And I was really interested in being a clinical psychologist originally. I went to school back home, going through the psychology track, undergrad. And halfway through my undergrad program, I stumbled upon a social psychologist who was doing some work around stigma and women living with HIV in Puerto Rico, in the Dominican Republic, and Haiti, and doing some cross-country comparisons as to how stigma manifested in the lives of women living with HIV. And I got tasked with doing interviews in our kind of HIV clinical center. This is on a rural side of the island on the West Coast. And that was really transformative. I realized very quickly that I was not the person to listen to problems. So clinical psychology was off the list really quickly. I was thinking about community level change. I was thinking about policies that were harming women and were harming queer people. And so I really stumbled onto public health through conversations with faculty, and I am proud to say that I am a Michigan alum through and through. And I fell in love with their program. At the time, the public health program in health behavior had a accelerated track, so you would do your MPH alongside your PhD. It was kind of unique in that way, but it forced you to take your MPH practical skill sets and align it with your doctoral theoretical training. And so I did that, and really wasn't even thinking about LGBT health at the time. I think, my own journey, I wasn't ready to like put the personal into my work. I was actually more interested in adolescent resilience and thinking about racial disparities in adolescent health behaviors. And it wasn't until I got to my postdoc that I decided to transition now to formally think about HIV prevention as kind of the main area of my work, and LGBT health, and kind of the larger nested set of social conditions that put us at risk for HIV and many other things. And along the way, my mentor, who is now, he's Argentinian. The word for retirement in Spanish is jubilo. It actually means joy. So he is joyful. Was really interested in working with pharma and NIH program officials to think about microbicides, which are these devices, technologies, whether they be lubes, suppositories, inserts, vaginal rings, that could actually be used to prevent HIV by delivering drug. And as social behavioral scientists, our job was to work alongside them in clinical trials and figure out, what is the participant feeling? How are they talking about this with their partners? And it was the first entry to kind of think about, pharma actually isn't the devil, right? I mean, many of us in public health were trained during a time where the spirit of 1848 and APHA really kind of grounded a lot of our work around social justice and thinking about capitalism as a negative factor in population health. And I had to reset, right, the theoretical political science side of public health with the day-to-day, like, how are we going to get innovations out into the world? And I found that, in fact, many of the folks that I was talking to were eager to understand how social sciences could move the needle, how quickly they had to pull out a product that probably wasn't working, right? So instead of assuming that just keep going and we're going to force participants to do this, even if the product is not acceptable, they were open to saying, wait, let's pivot and think about what needs to change. Does the vaginal ring need to be more malleable for insertion? Does the lube, when it gets hot during sex or humid during sex, does it become gunky? Does it, right? So like there's these very fundamental kind of engineering questions that they wanted public health to be at the table. And then I fell in love with technology. And I'm an old school OG technology person. I was really interested in thinking about how do we bring public health into chat rooms back in the day. Chat rooms.
Those AOL.
AOL, CompuServe,
Yeah.
K.com, to deliver HIV information and resource in that space. And that has kind of grown over the years.
I love that. And I think that story of kind of how you got started in public health feels probably so relevant to so many of us who have made our way into this space, sometimes with intentionality, but sometimes by accident. I want to go a little more into that kind of movement into the commercial or entrepreneurial space. As you know, we just launched, and as all of you know, we just launched at our School of Public Health our new vision statement and strategic plan last week. And we've declared that our vision is of YSPH linking science to society, making public health foundational to communities everywhere. And in that linking science to society, there is, as you've mentioned, a tension between social justice and entrepreneurialism. We actually have entrepreneurialism in the strategic plan. And we did a survey of all of our students, faculty, and staff, and I got some feedback saying, to your point, that's too capitalist, that's not what we're about. You've thought about it differently. You've thought about it as a yes and. And I'd love for you to share a little bit. You said that you don't see pharma as the devil anymore, which I think is good. Like, we look at COVID vaccines, we wouldn't have them in our arms if it weren't for Pfizer and Moderna. But you work outside of academia in a lot of different ways. Can you share a little about that and about the ethos of Eidos?
Sure. I think I'll start by kind of flipping the narrative that we're in a moment in our society where public health is the devil for many communities. Right, and we've seen that through COVID. And I hope that we can all agree that that is not true, I hope. But in fact, that depending on what value systems you're kind of holding on to, you're going to make different value propositions and judgments about how you perceive the world. I had to be able to do the yes and that you were talking about. Like, yes, I believe that increasing prices for medications for communities that can't afford it is morally unethical from a social justice standpoint. And I can also understand that if we really want to make big population health changes, we need to have better treatments, right? And so that tension I live with. Mm-hmm. I grew up as a public health trainee. I was actually talking to Dr. Ransom about this when evidence-based interventions was like the new thing.
Evidence behind interventions?
Yeah, and for HIV, the CDC had a repository that still exists, and so if you find that your intervention is efficacious, you send it to the CDC, they evaluate it, they put it into a portal, and any community-based organization can download it and implement it in their communities. That sounds awesome. But implementation actually requires adaptation, requires tailoring, and requires sustainment. There has to be revenue to be able to employ the staff who are going to be delivering these programs. And public health is extremely poor, right? When you think about infrastructure-wise, we really make things work with the best of our abilities, but we don't have the type of capital that venture capitals has, that we don't have a revenue system like corporations or small businesses have to ideate, think about something new. And so I started thinking about, well, if I build an intervention, I had an intervention, a digital tool that worked so well that my program officer at NIH said, you don't need to do an R01, just go and commercialize it. And I said, how do you do that? My grant and study was not looking at value propositions from a return of investment for this. I did not think about an entrepreneurship plan to think about how do I take a public health product and now give it to somebody to commercialize. I had built a product using human-centered design, but I had not built a product thinking about how am I going to do market penetration and segmentation and show, that there's a return of investment for users in that way, nor a revenue structure to say. And I think that this intervention, if you like it, costs X dollars either to payers, to insurers, or to some other party through ads or other metrics that we can use to commercialize. So fast forward, evidence-based interventions are an archive that aren't used to the scope and scale that we wanted. Our trials are frustrating because we spend a lot of time and energy recruiting samples for clinical trials, whereas the private sector gets exponentially the number, greater number of individuals who we could recruit for these trials at a scale that we will never get, right? So I can build a mental health intervention by myself and then recruit from my local community, which has value and is important. I'm not saying not to do that. Or I can think about an intervention that I can plug into a larger infrastructure that already has a client base. And the way that I think about it, and this is a safe space, right? So I love NIH, I love my funders. There's a disclaimer at the bottom of the Zoom, great.
And
when you think about digital tools, for instance, imagine building a tool that's going to take 5 years to test its efficacy or effectiveness. If I was an entrepreneur, if I was a startup, a small business in Silicon Valley, and I walked into a boardroom and I said, I want you to give me $2.5 million as an investment to start this new technology, this new bot, chatbot, whatever you want to build, but I won't be able to come back to you and tell you if it worked in 5 years, you would be laughed and kicked out of the boardroom. And so when we're thinking about real life applications that have public health impact, at least in the context of technology, we have to accelerate the pace. And there are different ways of doing that. And this is where I'm always thinking about, like, how can I advocate for NIH funding and rigorous science, and also think about other models. One is to partner with the private sector and think about, can we build something together? And there are mechanisms to co-fund that work. Another one is to push our biostats and epi colleagues to help us reimagine a new type of clinical trial that isn't a randomized trial, because we can't do 5 years of an assignment of 2 conditions and wait for it to happen, right? In engineering, in the business world, we're all actually receiving, whether you know it or not, random micro experiments every day. So you open up your favorite app and there might be a new feature, a new scroll, a new algorithm has been changed, and you may not know it, but behind the scenes, the company is actually testing, is this new feature, this new modification better or more optimal for engagement, for commercialization, for a number of times you click and like something. Whereas in public health, at least in the traditional NIH framework, we're not doing those type of trials. And so I'm not saying it's one or the other. I think it's co-learning from each other and being like, oh, wait, like, why aren't we taking those models from the business sector and applying them to public health? And what can we give the business sector to expand the return of investments, right? So you still need to get money. I get that. Like, that is your business as an entrepreneur. But here are some other indicators that if you're tracking intentionally, actually might expand your consumer base, because you're talking about value-driven investments around health, social connection, belongingness, social support, you name it.
So there are two things in what you just said that I want to pull on a little bit. One is, right, you are still at heart an academic. And
Nerd.
there is
Yes.
And there's that tension, right, between the science and the entrepreneurialism. And how do we do really good, high-quality science while also trying to get it out into the world? And so I'd love for you to kind of talk about that a little bit. But the other side of what you alluded to but didn't say out loud is something that you and I talked about this morning, which is that, and I frequently say this to people, if you're going and doing a pitch, right, it's the same thing as writing a grant. You're saying, here's the need, this is why my team is the best, right? This is how I'm going to think about overcoming problems. Like, the business pitch is actually the same thing as writing an NIH grant. You just do it a little more succinctly. And you did that in your classes back when you were, like, in the very first class that you taught back at Michigan. So if you could pull on both of those, like how we as academics can think about this intersection without giving up our deeply held belief in the value of high quality science.
Yeah, I'll start in reverse order if you don't mind.
Not at all. You always like to do that,
I know,
which I appreciate. Changing the frame. Changing
recency,
the frame.
recency effects. So I used to teach the program planning class for the first year MPH students in health behavior. It is the class that nobody wants to take, but it's the only class that I still have students to this day that I see them in a PHA and they're like, oh my God, it's the only binder that I still use and my day-to-day job. And I'm like, I was telling Megan, like, I know how old you are if you're still using a binder or a course pack, which means that I'm really old too. But but part of what we were trying to do, and what I've always believed, is that social justice requires us to come together. And I think the best way that we know that is we really value community engaged work. We think about social advocacy and community organizing as fundamental to the work we do. I think then as a public health professional that my job is to convene people, that I have to be able to bring diverse sectors together and really kind of learn a universal language. And program planning does that for me, which is why she knows that I'm a nerd. And the example that I would give in class and that we work through is you're doing your public health needs assessment of a community. And you're going to the census, you're looking at maps, you're figuring out what are the businesses in this particular community that you want to leverage, kind of their buy-in if you're going to roll out a community level intervention, for instance. In the business world, that's called market segmentation. That's called an audience analysis. And you're basically trying to ask the same question. What is going to motivate somebody to want to adopt what I am proposing? What are going to be some of the drawbacks? How is what I am building, this product that I am building, going to solve a pressing issue in their day-to-day lives? Because if I don't do that, they're not going to be able to actually do what I want them to do, right, for their own well-being or their community's well-being. And so that's like a good example of like, here's a public health skill that we all are ingrained to learn about. It's the same research methods, and yet the way that we have to talk about it and perhaps some of the analytics, if that is going to be a little bit different in the business world, you can be the one to kind of be like, oh, when you're talking about that segment, we talk about it as a subgroup or this particular community. And so that's really helpful to be able to flip scripts in my head. And it's also helpful when I'm writing grants because it actually makes porting an idea from an NIH application to a private venture capital initiative much easier. I'm not reinventing the world. I'm changing the words that I'm using within the same world, if that makes sense. Your second question, I totally forgot.
It was the science versus, like, how do you keep the science present? So how do you that commitment to doing really good science? You're not doing kind of low quality science. It's one of the things I admire about you.
Well, the jury's out on that one, but that's very nice of you to say, because my internal demons tell me that everything could be better.
Our internal demons always tell us lots of things.
Always,
so,
right?
Yeah.
The imposter syndrome. But, so at Penn, I have started a university-wide initiative called Eidos, or Eidos, depending on how you want to pronounce the Greek. We're open to both pronunciations. And the intent was to be a convener to think about social entrepreneurship around health equity for LGBT people. I don't have enough faculty at Penn or even across the United States. I wish I could replicate John and Trace 50 times, times 100, right? To think about syndemics, mental health, and the things that make us sick because of just who we are. I wish I could do that. There aren't enough of us, LGBT faculty or faculty invested in LGBT health right now in the US, to be able to be doing interventions at such a scale that we're actually moving the needle faster. So I, the voices in my head, was really interested in thinking about, engineering, medicine, the business world, as academics, have figured out a way to do science and think about tech transfer, think about patents, think about the fact that we are not going to be able to do it by ourselves, and so we have to reach outside of the university to do things. And I think public health has been slower into that discourse, and I'm not really sure why, and I'd love to have that conversation if you have ideas about it. And so at Eidos, sometimes we have companies come to us and say, I have a need. Before I go back to my venture capital group that's funding my work, I need some help with data analysis. I need legal counsel. I want to think about if this new slide deck that I have for my pitch is as effective as I think it's going to be. And so we've used Eidos kind of as a convener. I hate to use that word, but it really is what it is. And our job is to then reach out across the schools at Penn and say, hey, here's a company, they have a slide deck. Do you have a group of MBA students who are willing to workshop this with them? And the answer has always been yes. We were talking about a client who was thinking about the delivery of care nationwide, knowing that there are bans in place in some regions of the country right now around gender-affirming care. And the question was, how do we prepare ourselves for any litigation where we are delivering services at home to somebody's home in a state where the policy has been restricted? And so the law clerks, the law students actually have a free clinic, and they put a brief together. That brief was an opportunity for students to learn about LGBT work, do something that's kind of mission-driven for a lot of them, and get our clients basically a really substantive brief that saved them 20 hours of cost having to pay an attorney to do it, right? Because they don't have that type of cash flow necessarily lying around. And so those are moments where you can do scientific rigor. It's a learning opportunity for students and faculty alike. And I can do a survey and it's going to take me a year to do it, right, the right way. Or I can just actually have an audience base already where I can consent and still do the scientific IRB regulatory. It still will have selection bias, of course, because people self-select into services and products. But the scale at which we can ask questions is really different.
I love how you bridge that and how you're able to kind of pivot back and forth from one to the other. For those in the school, of course, this will be part of Strategic Priority 1 from our new strategic plan with creating a hub to be able to do this both within YSPH, with Yale Ventures, and in partnership with other schools. So stay tuned. I'm going to go a little further into kind of your comments about the LGBT plus community. In discussions that you and I have had over the years, you've talked about kind of your goal of queering public health, which I love. And I wondered if you could share with the audience both a little more about that and also what it means to bring your lived experience into your work. I give you the easy questions.
Yeah, great.
I really excel at that.
I see how it's. I see how we're escalating the conversation. I have been part of a self-discovery journey. I think because my formative academic life was in HIV, and we have talked about resilience in a way that always means in the presence of risk, what do you do to bounce back from it? What do you do to mitigate its potential harmful effects? And that has been really important from a policy and kind of programmatic standpoint, that we are reducing population level risks that aren't necessarily individual behaviors. They can be social policies and limited access to resources. So I want to be really clear about it when I use the word risk, that I'm taking kind of a more social vulnerability framework to this. But I think about my life and I think about my friends, and I read papers, some that I wrote many, many years ago, and I have to pause and think to myself, like, wow, like, is this the best I could do? Is when I talk about young MSM, is this really the best language I had at the time to talk about why people are having sex? Why people are using drugs? And so I've tried to be much more intentional now to think about the power of words and what they mean. And I think as a community, we really are talking about like person first language, for instance, and what that means. But I think there are things that we take for granted in the community that actually would really help cishet people a lot. And that we haven't been able to fully celebrate and disseminate. So things that keep me up at night. Mm-hmm. We have a growing aging population where social isolation is kind of top of mind, where we're seeing families fractured for political reasons, socioeconomic reasons, geographic reasons. The queer community has figured out through pain and suffering how to recreate families. They don't have to be blood, they can be kin family. So why aren't we investing money, time, and energy to thinking about like that magic? How do we make that magic a public health priority? How do we think about, if we could really figure out when you are kicked out of your home because your parents dislike who you are, how do we understand how people come together to thrive and to support one another? And think about packaging that as an aging in place intervention. That to me is queering society. It's an opportunity to take back the fact that we are who we are, and we actually, in adversity, are able to be who we are. And that's magic. And that can be said the same for I think about it like as a Puerto Rican, thinking about climate change. Mm-hmm. There are choose intersectional identities and again, reimagine something good has to be happening, right? And so let's call those out and try to do a problem analysis, a resilience analysis. I don't even think it's resilience. I think it's a protective factors analysis. And let's build that type of intervention as opposed to the risk response intervention.
Yeah. I think that focus on joy, right? On enjoyment, mm-hmm. on positivity, is such an important message and lesson. And when you as you were talking earlier about how many people do see public health as the devil, I think that's part of it, is that we're seen as being
controlling.
Right? Controlling, don't enjoy yourself, don't do this. And the vision that you are presenting is the flips, it's the yin yang, right? Like it's the flip side of it.
Yeah. And there is a middle ground, but even how we talk about that middle ground is problematic. We call it harm reduction. Right? It's like, well, why does it have to be harm reduction? Why can't it be, getting to joy? It's not an Oprah hour. I'm not, unless is there a gift?
I do actually, but yes.
But I think that, psychology has made strides in positive psychology. In the communication science disciplines, we have seen that emotions, both positive and negative, are what fuels virality of things. So a post that has either a very positive emotion to it or a very negative emotion is not only what gets disseminated faster, it's what people remember, even when you then try to address the misinformation, right? And so we have to learn from those advances in other sciences and bring them back into translation into public health.
And I think it's a great challenge for all of us in the room as we think about our future, as we think about defining what we do for our kids' kids, our nieces and nephews, the communities around us, to make ourselves something that people want right? Which is the trick, because at the end of the day, human behavior is a really strong thing, and human behavior, yes, there's a fear aspect, but there's also a pleasure-seeking aspect.
For sure. I mean, I no longer do clinical prevention work, but one of the things that still surprises me when I do focus groups for intervention building and human-centered design work is I'll ask young people, like, tell me about, what is that you want this program to do for you? Like, what is that big job, right? And kind of the job pains and gains entrepreneurship value proposition canvas that we use. What is that big job that you're trying to solve? And for young queer men, the job is teach me how to date. And I'm sure that's true for many more of us. Tell me how to be a good husband, right? And yet we are reticent to actually build an HIV, STI, comprehensive sex education set of programs that actually say, this public health program is actually a dating coach. And we're going to help you figure out what it is that you want and what are you actually doing and where is there dissonance and how do we help you kind of breach that, right? So to that humanity piece, I feel like we overthink what our communities really want from us. And so engaging in community, whether it be through community-based research, whether it be through human-centered design work, whether it be working with consumers, it gives you insights that we perhaps have been too scared to even dream about. And I think it's okay to dream about these things. Like, I want to be part of a generation where I can say, as a public health scientist, I actually started giving people life skills. And because I give them those life skills, that's how I saw the behaviors change, whether it be now or later in their life course. That's the dream. I can't do it now, but that's a dream.
Vision, yeah. And I'm totally signed on. So count me in. I'm gonna do one more question and then kind of open it up to the audience. I've got a bunch more that I can ask, but I want to give all of you a chance to ask your questions of this amazing font of wisdom. No pressure.
No pressure.
But one of the things that you and I spend a lot of time talking about is both where we've come from, what our peer networks look like today, and what sort of wisdom we wish we'd known and how to impart that to the next generation. I think it's something that keeps both of us in academia, is this idea that by being in academia, there are generations beyond us. And I'd love, you have some brilliant pearls, again, no pressure, but that have helped me through the years. And so I hope, kind of looking out to this audience, which is about half students, as well as some junior faculty, are there things you wish you'd known going back? Like things that for folks that are either kind of getting started or at a transition point in their career that they might benefit from?
Oh boy. Sure. This will be like a random brainstorm.
List. Yeah.
And I promise not to spend too much time meandering. I have a wonderful mentor who I had the pleasure of learning how to teach from when I was in Michigan. And he was an individual behavior scientist. His name is Vic Strecker. And Vic was an awesome teacher and would teach the fundamentals of public health behavior change theory to an auditorium of 200, 250 students. I actually took over that class when I became faculty after grad school. And I remember always asking myself, like, why do you love this class? It's in some ways it's a very boring class. You're going to talk about the theory of reason action. Here we go. Beliefs, attitudes, norms, behaviors, and intentions.
It works.
Yeah, but his answer has really stuck with me, and so I give him credit, and I believe this fundamentally as to why an academic is that our job is to build interventions and policies. And teaching the next generation of public health leaders is a structural intervention. It's not an individual level intervention. I can build one intervention a year if I'm really good at it, which I'm not, right? It's usually one every three years. Or I can teach one semester 200 students who can then work in areas that I don't even think about moving forward. And I then start multiplying that year after year. And you all of a sudden have contributed to the public health workforce. So that to me, the necessity of having faculty engaged with their students is super important to me. So that's one. So it's not a chore, it's an investment in the next generation. Two, you're gonna fail a lot. So this life skills program that I've been working on for 7 years now, we just finished the trial and there was no effect size. And we have participants telling us like, this was transformative. This was really helpful. The peer mentoring sessions delivered online were exactly what I needed. But when you look at the outcome indicators that we had, there is no movement of the needle. And that might be many reasons, but it's demoralizing, deflating. And ego aside, it's like, did I fail as a scientist, right? And the imposter syndrome starts. And you have to kind of stop yourself and be like, that's what science is. That's why it's called a trial. Because you're going to put your best work forward, and sometimes it's just not going to land. But that takes a lot of licking wounds and being open and vulnerable to talk about, like, yeah, well.
It is the biggest. It is the big.
It is the biggest.
Did you mess up the science? Did you mess up your outcome measures? Did you mess up your intervention design? Or is it just not a thing that works?
Or is it just not a thing? And the pandemic was a thing that happened in the middle of this trial. And so, I mean, there are many reasons as to why we're trying to figure out so we don't repeat the same mistake. But there's a lot of shyness about not admitting when things don't work out. And I think that we owe it to the public. It's federal tax dollars. It's our tax dollars, if you want to think about it that way. And we have to also report the null findings and be like, hey, we tried. And they loved it, but it didn't work. You know, there are tons of programs like that in the world that might have a really good kind of feel-good sentiment, but scientifically didn't do what we proposed them to do. And then last, and then I'm going to shut up, is to really think about what else moves you. Mm-hmm. So I met Megan at a time in my life where I had just been promoted to full professor. I must have been like 35 years old. And I had been go, and my husband had got cancer. And it was a really great moment to recognize three things. One is that this is just a job. Two, that we're all in this together. And if you need to check out because there are more important things in life, like caring for somebody that you love, that if you have a team, your team is actually going to be there for you so that you can actually reprioritize the same way that hopefully I will be there for them when they need to take care of loved ones. And three, that the work actually is still going to be there. So it's okay to kind of pause, be a human, and come back and be an academic. And had I known that, I perhaps would have slowed down a little bit. I would have been as intense, but I think I would have slowed down a little bit more to enjoy the ride. Half color, like the grass is greener on the other side. Easy for me to say, right? I'm a full professor. So I don't mean to dismiss that kind of anxiety that early stage investigators and associate professors have. But at the end of the day, like I'm grateful that I had enough cues in my life that were like, it's okay, pause, fix this, Yeah.
Well, and if I can add in there, I think we got to know each other at real transition points for both of us, mm-hmm. and your transition into Eidos, my transition into academic leadership, and then to here, you were part of my decision to come here. I think just to add on to that you said the team, and there's the scientific team, but there's also the peer team, mm-hmm. which extends further than your own institution.
For sure.
And I think that's something that you've cultivated tremendously intentionally over the years.
Yeah, and it takes energy, and sometimes it brings disappointment. I mean, there are people who I loved as friends who are no longer friends because that is life. And there are other people that I couldn't imagine not calling, whether they work in academia or not, that I wouldn't imagine not being able to call and be like, this thing happened. What do you think about it? You know? And have that mirror be like, maybe it was you, right? Or, oh, wow, that was really difficult. You know, let's problem solve it. But that's, I think that's like part of the magic. It's like we have amazing opportunities to like engage with one another. And so I hope, you know, for the students in the room, I do hope that you spend time kind of cultivating relationships. To me, it's like a muscle. It's a skill. If you can practice it here in a safe space, and then when you start going to conferences and, you know, you use it again with more awkward moments.
It's kind of like dating.
But don't do that.
Thank you.
Yeah.
I'm going to open it up to all of you. Holly walks around, Holly walks around with her Phil Donahue version of the microphone, and then also to folks.
Donahue.
Oh, I'm totally dating myself there. And to folks on Zoom, please feel free to chime in as well. We will get to some Zoom questions too.
Sorry, I'm just going to unmask, but I'm a little congested, so I apologize. Thank you so much.
I'm going to move away now.
Thank you, Dean Rainey, for your questions, and thank you, Dr. Bauermeister, for the wonderful, wonderful talk, drawing so many parallels from like within the field of public health. And then I needed it for like business. Until this year, I really didn't understand the concept of money and how it influences a lot of the work that we do. But I also really liked your point about querying the vision, like for public health. Something that I have a question related to is like this vision. I'm going to offer a comment before I make my question, since it explains it a little bit more. When I think about a vision for querying public health, I truly think about transformative justice, which begins with inclusivity. And I feel like a lot of academic discourses that I've had tend to water it down, partially because of, you know, like whiteness or white saviorism. So I wanted to ask, how can institutions, and I want to be very intentional with my use of the word queer, because that also tends to dilute experiences. White cisgender gay men don't experience the same experiences as me, someone who's like a brown person of color who's also a gay man. But I wanted to ask, how can academic institutions, such as Yale School of Public Health or Harvard or anything, uplift Black and brown, queer, and transgender voices? Because I also do think the queer community can sometimes be very exclusionary to transgender people. So just wanted to hear your thoughts on that as we move towards a queer future, as I call it.
I love that question. And it is I don't have an answer for it. I'm going to tell you the steps that at least we take at Eidos. So for us to support a project through Eidos, there has to be at least two sectors involved. So it can't just be that a company comes and says, hey, help me out. We will try to match them with a community-based organization or a social advocacy group. We are diverse, but we are nowhere reflective of everybody that needs to be in the room. And so we are really intentional about participatory processes. And so, for example, we have created a advisory board for a project so that folks through Philly or nationwide can chime in and direct some of the non-academic work for us and with us. So that's one. I think two is if you're a student and you can, there has to be, I'm going to make a bold statement. I really hope that Yale has an intersectionality class that you can take, or I'll shamelessly plug my fellow Philadelphian, Dr. Lisa Boleg, who has an intersectionality institute, which includes a newsletter every month about how do we think about psychology and public health and intersectionality frameworks, that really starts going at the power differentials. I think the last thing I'll say is that whenever I can, I do have community engaged principles in the work that I do. And let me be really careful here that does not mean an unpaid advisory board. I get paid for the work that I do. They need to get paid for the work that they do. And if I can't put them in my budget, then the work isn't going to happen. And oddly, all of a sudden the money does show up, but you have to lead with that value, right? I think there's a pipeline problem. I am one of a handful of Latino gay scholars in this space. I worry about that. I worry about Supreme Court decisions of anti-affirmative action policies and how that's going to affect kind of higher education more broadly. And so I share that because sometimes I also have to think about, like, well, I can go into a framework of doom and gloom, or I can think about, separate from my job, how am I a citizen, right? It's election season, everybody. I hope you're registered to vote and voting. Because part of it is I also have to remember that I can't be a passive consumer of it. And then that takes time and energy, and sometimes I have to call myself out and be like, wow, I should have really gone to that community board meeting and I didn't. And then I also have to then hold myself with grace and say, like, but I'm exhausted, and then I would be performative to just show up to a community board. So it's not it's not an answer, but it is kind of those sticky places where I totally hear what you're saying, and we all have to collectively continue to reimagine it.
All about just doing the work and creating space for others,
yeah,
which you do so beautifully. Next question, yeah.
We should have just kept the microphone.
Yeah.
Hi, thank you so much. I really appreciated the talk. You mentioned the Supreme Court briefly in that last response, and I guess I just wanted to ask about how, as a person that does LGBTQ health research, both for like with the more entrepreneurial lens of intervention, and then I assume also there's like the weight of the impending policy and Supreme Court decisions, how do you balance focusing your research on the intervention and these health outcomes that you've been talking about measuring with also like what are the repercussions for the policy sphere around like really contentious issues, especially where science is often debated or called into question around LGBTQ health issues?
So I think you can make anything into a research question. And that's the way that I've thought about it. So like I currently have a postdoc, newly minted Dr. David Yu. David was really interested in health services research and thinking about, he's trained as a nurse practitioner, was really interested in understanding how are different hospitals delivering care differentially across the country. So we actually reached out to the Human Rights Campaign, we got their health equity index. We then matched that data with hospital level data for his dissertation so that he could then do an analysis of like state level policies and how it's actually contributing to hospital outcomes, either directly through policies tied to inclusivity, which the HEI measures, or through patient outcomes. And that has been fascinating to see him lead that work, both because he's a clinician, but also he's a scholar. And my job in that space is to just support and pose questions. I think we need much more of that work. So at Michigan, when I was a grad student, we were all deeply and strongly encouraged to take multi-level model classes, which allows us to match kind of community or kind of structural level variables, predictors to individual level outcomes. If that is something that you're really interested in, take stats 1, 2, and then go look for that class, because it allows you to ask the questions in ways that I think a lot of the data is increasingly available. We just have to, we need to create a little army that is a science-based army. That does not erode the fact that I think I kind of heard in the subtext, which is it's not like legal decisions are being made out of scientific evidence, right? And I think that's where doing that translation that Megan was talking about of like, so how am I writing this paper or this policy brief so that HRC or the trans collective can take it on and do their work that they are trained to do well around civic action. But again, that takes kind of some road mapping and intentionality. And ultimately, we are at the whim of the Supreme Court. The only thing we can do is vote, right? The civics part is to be active and present in our local, state, and federal elections.
And I'm just going to double click on the local and state, right? Which make a really, really huge difference in addition to federal. Mm-hmm. So, great question. Did we have any questions on Zoom or?
Not yet.
Okay.
Hi. Oh, sorry.
Yeah.
Hi, I'm Bryce.
Hi, Bryce.
Thanks so much for being here. You mentioned the need for public health to move from risk to joy and thinking about different ways of like what brings us together. And I think that's super important in reimagining like the types of questions that come from that. And however, many public health risk-based models have been perched at this individual level responsibility and the debates of identity politics. And I guess like if we do see a way of like thinking about joy and other ways of like being relational to each other, how do we ensure that it's not trapped at like the individual level? And how does joy look like? What does joy look like for structural implications? So yeah.
That's an awesome question. That's a dissertation question, y'all. If somebody's looking for a dissertation. Dr. Ransom over there is probably somebody you want to talk to because I think about beyond, we actually talked about this morning, beyond belonging, which is how I think of the individual level piece of joy. Like I belong, I feel like I'm part of a group. At the network, at the community, and at the state or country or global, you can even imagine some global indicators of this. We can start thinking about things like connectedness, social capital, as well as some like socioeconomic drivers at the true structural level, like income inequality. I want to believe in a world where if people actually feel like they belong and they are netted to one another, then we do have many more entries to talk about political and socioeconomic reforms to address the income inequality gaps, right? That is a pipeline dream, but I think we have to call it out so that scientists like Yusuf can actually then go back and be like, I'm gonna add a variable to my multi-level model homework. So I think we have to do that. And I think you're absolutely right that there's the peril of the individual level versus the more upstream versus downstream. Let me use that language. And I think it's a false dichotomy. I think that as somebody who was trained in all of these theories and teaches all of these theories, I'm going to quote the vice president, there are more things that bring us together than divide us. That is my political campaign for the season. And I think that's also true. There has to be individual level behavior change while structural change happens. And sometimes we need structural change for the behavior change that we want at the individual level to also happen. So I don't think it's one or the other. I think it's being able to come together in dialogue and figure out like, okay, what part of this multi-level framework are you working on? And are your values and assumptions in alignment with the ones that I have? And right now we don't do that, and that's where things fall apart.
Which of your values are in alignment? Because none of us are going to be perfectly aligned, and I think that one of the things that you've done so sorry to interrupt, but like I just want to call out like one of the things that you've done so brilliantly is to find those spaces of alignment, even with unlikely bedfellows.
Yeah.
So
for sure.
Yeah.
So I don't know if that helps, but again, I think it's just like sitting down and doing kind of an assessment of values, value propositions, and what part of this really complex world are each of us contributing to?
We have time for one more question if anybody wants to have the last word.
Yay.
You voted.
Yes.
Yes, I highly recommend it.
Voting?
Yes. Early voting. It was crowded. So and we're in a solidly blue state, but people are showing up. And that's actually kind of part of what my question is. I really appreciate your work. The number of times that it shows up in my email lately, I was really pleased to see that you were coming here. So it was great to listen to you. I am asking a question that hopefully won't be super vague. I've been working for a number of years with a few folks here as well on trying to get an actual LGBTQ healthcare program at Yale. We are unique amongst our peers in that we do not have one. And just recently we learned that through the budget process that our program, along with many others, are just not moving forward. And so it's been very interesting to listen to you talk about the making a pitch, and this idea. I think that because we're in a safe state, that there's maybe a little bit of benign neglect also at play here. And so I'm just kind of wondering, do you have any thoughts about, how we can take the population health aspect of it, to bring that to bear to the decision makers who are having to, look hard at a budget and dig out of a deficit, largely because of the pandemic?
Yeah. Another, I'm not sure that I have an answer for you, but I'll tell you some of the things that we have tried to do at Penn. So Penn Medicine has an LGBT health program. It is not a LGBT health clinic. We also have kind of debated, should we open an LGBT clinic? And that, from a Philadelphia landscape, is much more complicated because there are many FQHCs that care for our communities that Penn would be competing against.
Yeah.
And so ethically, is that the right move? The LGBT program at Penn Medicine is wonderful, and it actually serves as a technical assistance hub so that different subspecialties can actually build capacity and do some patient navigation if needed. It's imperfect, but it's a place to start. It's actually part of the med school's diversity, equity, and inclusion and belonging office. It's one of their pillars, along with race and gender and socioeconomic position. So thinking about, I'm not saying to recreate this, but thinking about who are the champions in healthcare at Yale who might be really interested in talking about equity in a new way. So my husband is an ophthalmologist. He actually does, his subspecialty is in plastic surgery. So like anything that's to do with trauma in the eyes is what he sees. But actually for trans communities, for instance, who are trying to either feminize or masculinize their body, a lot of the work around fillers, Botox is actually part of the work that needs to happen. And so we have worked with Derm and his practice at Penn Medicine and other units to think about Saturday clinics where residents and interns can actually learn how to deliver inclusive gender affirming care, also deliver services to the community, whether at a sliding fee scale or get revenue from it. So that's one way of kind of like integrating the pedagogical part of medical education. Let me just be careful. Healthcare, my nurses, I don't want to leave them behind. Healthcare providers. And we've, on the Eidos side, have actually started helping people who have interest in looking at the sex, gender, and sexual orientation indicators in the electronic medical record to analyze the data for them so that they actually can then go to their chair, right? So part of it is like a game of, okay, at the division level, we don't know if there are disparities outside of sun tanning among LGBT communities. There are many, many other skin conditions that we've never been able to explore. Let's look at the chart data and give them a reason to go advocate, within that division. And so I think if you start thinking, we do it with dental medicine right now. We're doing a lot of work with the dental school, and they've been a wonderful champion. And I've learned a ton that I didn't know. Like the dean there is a stout supporter of LGBT health and schooled me on the fact that when you're taking hormones, your gums change. Mm-hmm. So your technician, your dentist actually needs to ask you questions about gender affirming care because it's part of the treatment plan that they're looking at, right? I was like, I didn't know that. So there's just a lot that we don't know. And unless we start kind of small and start building value propositions and case studies, it's harder, but I think we can get there. I don't know if that helps.
And I will say for, as I'm sure well, we have now a 3 Deans Council around LGBT, right? LGBTQ plus health.
Oh, cool.
So a thank you to John and Donna from the School of Public Health side, and to you as well, right? And so thank you for the work that you do, but and I'm saying not to you, but to the group at large, and thinking about how we can use that is a is a great tool. So with that, I will close things. We've kept you all a teeny bit late, and I'm appreciative of that. Jose, thank you for coming. Thank you
Thanks for having
coming
me.
with your full self. And helping to hopefully illuminate a path forward for many of us. Opening the aperture of what's possible in public health, in academia, in living. And most of all, I think taking, for many of us, taking, if nothing else, that pursuit of joy away from this discussion. Sure. I would be remiss to not share some swag with you because we are Yale. And so I do have my little Oprah
under the seat.
Yes, the Oprah under the seat for you, my friend.
Thanks.
Enjoy. Thank you.
Thank you.
Warm round of applause for Jose. Thank you, my friend.
Thank you for coming.